Good morning, everybody. I hope you slept well last night, and we are happy to open the second day of our WONCA virtual conference from Amsterdam. We are from all around Europe, and I hope that everything will go okay. I want to introduce our first speaker, Dr. Monika Hollander. She is a general practitioner with special interest in cardiovascular diseases. She is working at the Julius Health Centers in Utrecht. She does research in the field of prevention of cardiovascular disease at Julius Center, UMC Utrecht, and she is active in the Dutch Association for General Practitioners with a special interest in cardiovascular diseases. And she is also active in the European Primary Care Cardiovascular Society and the Primary Care and Risk Factor Management Nucleus of the EAPC. Monika, the stage is yours.
Thank you very much, Shlomo. I would like to thank the organization for giving me the privilege to talk about cardiovascular risk management and challenges for primary care. I'm now sitting at my kitchen table, and it's very surreal to talk to a large, important audience for primary care. But I was also thinking this is what we as GPs are also doing, sitting at the kitchen table, talking to patients. So let's go and do this. The outline of my talk will be first to comment a little about the Eec CVD Prevention Guideline. And then I will discuss the role of general practice in the several issues of the guideline, and especially regarding screening for cardiovascular and cardiometabolic diseases. Then I will discuss cardiovascular risk assessment and management, and also the challenges for primary care, challenges in treatment, and then I will wrap up with a conclusion. First, I would like to point out some elements of the Eec Prevention Guideline. Here you see that almost 5 years ago, the European guidelines on cardiovascular disease prevention and clinical practice were published. It was an Eec guideline, European Society of Cardiology, and it was a joint task force with involvement of also other societies. Also, delegates from WONCA were included. And well, in this year, we know that there will be a renewal of the guideline. And I think I would like to invite you to check the new guidelines if they are out, and to see if there are some new directions for patient-centered care and shared decision-making, because this guideline in 2016 started with it, and I'm sure that the new guideline will work further on this topic. And what does the Eec guideline that is published several years ago telling us about the role of general practice in screening for cardiometabolic diseases? And I want to point out a table that is in the guideline, and where the guideline says who should receive cardiovascular risk assessment. And I would like to start with the lowest category at the bottom. And of course, systematic risk assessment in younger people without known risk factors is not recommended. And I don't think a lot of GPs are doing this. But what about systematic risk assessments in men and women over 40 and 50 years of age who do not know, are known with risk factors for cardiovascular disease? Are GPs doing this? Do we have a role, and is it effective? Well, let us look at the evidence for this. What is known in the literature about health checks for cardiometabolic diseases? First, in 2014, we have a colleague C that published a large overview on effectiveness of general practice-based health checks. And the conclusion there was that health checks in general practice was related with significant but small improvement in surrogate outcome control. And you can think about blood pressure control and cholesterol and other cardiovascular risk factors, but it was especially seen among high-risk patients. Later on, in 2019, Croxball published a Cochrane systematic review, and he studied all available studies at that time. And the conclusion was that health checks have no effect on cardiovascular disease, do also not have an effect on cardiovascular morbidity and mortality, and it should not be performed. And well, in the discussion, he wrote that maybe GPs are maybe already very good at picking up cardiovascular risk in their regular practice. And to close this discussion, in 2000 or this year, one of our researchers in Utrecht, and we were also involved in this trial, published results on a trial. And this trial studied in 30,000 patients the cost effectiveness of a stepwise cardiometabolic disease prevention program carried out in primary care. And the conclusions there were very clear. There was a significant decrease in blood pressure and cholesterol levels, but this approach in primary care was by no means cost effective in long-term endpoints. And cost effectiveness could also not be achieved with better treatment compliance and lower intervention costs. So to conclude this question, GPs should not be involved in systematic risk assessments in patients who are not known with cardiovascular risk factors. But what about cardiovascular risk assessment and management? Those are the upper bars. And here you see that the recommendations are for systematic cardiovascular risk assessments in patients who are known with risk factors. And it is also recommended to repeat this cardiovascular risk assessment every 5 years. Do GPs perform this, and how can it be done? And what is the best way? Is it systematic or opportunistic? And also given the fact that the organization of GP primary care systems are very different across Europe. So let's have a look in this. What about systematic screening? Systematic screening means that you scrutinize your patient population and invite potential high-risk patients very actively. And we know that in some, but far not all European countries, programmatic cardiovascular risk management in general practice is organized, and in some countries it is fully reimbursed, but in other countries there is no such program in place. And some programs include screening of high-risk patients, and it's reimbursed, and in other countries this is not in place. Further, there is still an ongoing debate on the effectiveness of such a cardiovascular risk management program in primary care. For example, in the Netherlands, we have it reimbursed and it's carried out by general practitioners, and we have an ongoing debate with healthcare insurance companies that still want to diminish the costs on that. So there's, continuous debate, and it's difficult for general practice to organize it, and if you have organized it, to keep organizing it. So there are very many challenges to overcome. Further treatment options vary across Europe, and it's also very much dependent on the healthcare system that you are in. And of course, it's maybe an open door, but lifestyle treatment remains a challenge. Can GPs do it alone? And I'm sure that we need more efforts in the surrounding governmental actions, because as GPs we cannot stand alone in this. So there is a joint action needed here. Well, of course, what can all GPs in all places, in all times do? Opportunistic screening. So I want to introduce to you this person, Mr. Y. He is 65 years old, and he visits your practice for a sore knee. And he is now in the practice, and he's asking you to measure the blood pressure. And you make a check of his medical file, and you see that the last year, the blood pressure was 149/85. He is not known with previous diabetes or cardiovascular disease, and he stopped smoking last year, but he has been a heavy smoker. Well, you examine him and you do some additional measures, and you see that he is quite an elevated office blood pressure, 160/85, total cholesterol of 7, HDL cholesterol of 3.5, and the glucose levels were normal. It's not written down here. So, well, what do you do with this person and these measures that you do? There are several ways to do opportunistic screening, and I want to show you the ways how to proceed with this. The first one is to see in what risk category this person is. He's not known with cardiovascular disease or diabetes, so you can use the score charts. And the European guideline has score charts for low-risk countries in Europe and for high and middle-risk categories and countries in Europe. At the left side, you see the risk score for the low-risk countries, and below you can see what countries belong to the low-risk group. And at the right side, you have the high-risk score. And the score is indicating the 10 years risk of fatal cardiovascular disease. And you can calculate the risk based on the cholesterol levels, based on blood pressure, on age, smoking status, and whether you are a male or a female. And to add on, you do not use these risk scores if you are automatically classified as a very high risk patient. And it's mainly in kidney function or impaired kidney function, in patients already suffering from cardiovascular disease, or some patients with diabetes. They are automatically categorized as high risk. But this patient, and I take now a high risk category, is indicated as a very high risk, as you can see in the blue square, that he has a 10 years risk of fatal cardiovascular disease of 15%. And this is indicating that he has a very high risk, and there is an indication, at least for lifestyle treatment, and this does not improve medical treatment to lower blood pressure and cholesterol levels. Well, if you use these risk scores, there could be some problems with risk communications, because what does a single figure of 15% say? And also the problem with these risk scores is that, as you may know, that most elderly and few younger persons have a high risk. And if you're in between, how do you communicate about risk? And I think this is what the theme of the conference is all about. Lifetime risk, and there will also be a roundtable discussion later in this conference where this will be discussed. So see the program for this. We can use lifetime risk and risk age to do the risk communication with patients, and also the communication about risk and decision making together with the patients is very important for the further treatment. So what tools do we have for that besides the risk scores and the charts that are pointed out in the guideline? And the developments have gone further, and there is the UPrevent risk calculator. You can find it on the UPrevent website. If you approach the EEC, you can also find it, and there are also apps that you can download, so you can just calculate risk anywhere in any GP office. And you see here that there are several scores that you can use for patients with cardiovascular disease, for patients with diabetes and without cardiovascular disease or diabetes, and for younger and older risk categories. And you can, the left white squares are the shorter term risk, and the right white squares are for the lifetime risk. But for Mr. Y, I want to use such a calculator, I use the score for ASCVD, as indicated in red, And what you can do, you can fill out the data of this patient. And I have taken a low risk score for this example. And you can just fill out the age, the history of the patients, the measures that you have done. And as you can see here, this patient in this low risk score has a cardiovascular risk of 9%. And you can play a little bit with it. So if you, at the blue square, you can see if you lower the systolic blood pressure under 140 millimeters mercury, or lower the LDL until below 2.6, you can immediately see what the treatment effect will be and the benefit for the patient. So you can use these calculators and use these apps for risk communication with the patient. And I would like to encourage you to use it, because you can use it anywhere. Well, how did this go further? Mr. Y tried lifestyle treatment for 4 months, and well, there was no effect. And later on, the GP starts with an ACE inhibitor and a statin once daily. Well, then we have started treatment after opportunistic screening. And what are the challenges for treatment? As I pointed out earlier, also, there are differences in organization of healthcare system in general practice and also in reimbursement. And that is important. How much time and efforts can general practice put in controlling these patients and checking them up and following them up? And it's also related to whether you have support of practice nurses. In many countries, practice nurses do a lot of important work in cardiovascular risk management. And also the treatment options, for example, lifestyle, well, are very different across different, within countries also, and also between countries. And regarding treatment, I would like to quickly point out one of the challenges that we have there also, because last year the next survey of the EUROASPIRE study has been published and it's indicated that risk factor treatment in primary care. And what they did is they took a group of high-risk patients without cardiovascular disease on treatment for blood pressure and lipids, and well, they indicated across Europe how well this performed. And what you can see here, that more than half of the patients who are treated with drugs for blood pressure and lipids do not reach the treatment goals as indicated in the guidelines. And well, if you look at the title of the paper, then well, it is, well, I don't know what we think about this, but it could at least be improved. I think that we can all be clear about that. But how to improve? What does primary care need to improve this? And I would also like to point out that the following guidelines are getting even tighter, are giving even tighter treatment goals. And how does primary care deal with that? That is a big challenge. Some suggestions how to improve. Well, awareness in general practice is very important, and education of GPs in the GP training and practice is very important. And embedding of cardiovascular risk management in care, I'm very well aware that this is related to whether it is reimbursed or not. What role do societies play? I think they can play an important role. There are national GP societies with a special interest in cardiovascular disease. They are there in some countries, but not all. So it might be one idea to maybe develop this further. And we have the EPCCS, the European Primary Care Cardiovascular Society. This is a society of GPs interested in cardiovascular disease, with also conferences. They can play an important role in uniting GPs in Europe. And I would also like to point out that within the ESC, you have within the European Association of Preventive Cardiology, in last years, there is developed a nucleus for primary care and risk factor management. And it's multidisciplinary. And well, I am sure that cooperation within Europe, among countries and among GPs and with these organizations may be an important way to go forward and to improve cardiovascular risk management in primary care. To conclude, health checks for cardiometabolic diseases performed in primary care are not effective, and GPs have to play a role in opportunistic screening for cardiometabolic diseases. Systematic screening, as indicated in the guideline, is dependent on organizational factors, and we do not always have influence on it, but we can try to influence them if we want to. For GPs, I would like to invite them to use SCORE or the Eec Prevent app and websites for calculation of risk, but also for risk communications with your patient and shared decision making. Well, the treatment of risk factors in primary care needs improvement. And I would like to conclude that the role of national and international GP organizations, like, for example, the WONCA also, is very important. This is what I would like to share with you this morning, and thank you for your attention.
Thank you, Dr. Monika Hollander, and I would like to introduce our next speaker. And after his lecture, we will open the stage for discussion. You will write your questions on the chat, and Bert and me will help you to introduce your questions to the lecturers. So our next lecturer is Professor Xavier. Sorry for the barking of my dog. And Dr. Kos is a family doctor from Barcelona, a member of the clinical trial research units of IAP. Dr. Kos is an associate professor in the Faculty of Medicine of the Autonomous University of Barcelona, and for several years he works as a teacher in the Rising Stars program of the International Diabetes Center in Minneapolis, the United States. He is the president of the Primary Care Diabetes Europe. Dr. Kos, the stage is yours. You are mute. You are mute. Please unmute yourself. You are still mute.
Yeah, sorry.
Perfect. Perfect.
Okay. Is that okay now? Yeah.
Perfect. Perfect.
Okay. Thank you very much. First of all, thank you very much for inviting me to participate in this session. And thank you, Shlomo, for your really kind introduction. Yes, today I'm going to talk about multifactorial preventive intervention for diabetes and cardiovascular diseases. I'm going to mainly be focused on the diabetes prevention section. And this is my disclosures. And as I said to you before, my idea today is to talk to you about the role of primary care and the role in diabetes prevention. And I think it's really important to take into account for that, what are the aspects I would like to provide answers. I would like to go for some introduction, and I would like to provide answers of why, who, and how to prevent diabetes from primary care, and finally some take-home messages. It's clear that diabetes is a continuum disease. This is a long trajectory, and we start from the normal glucose tolerance to the prediabetes status, where we have impairing fasting glucose, impairing glucose tolerance, and moving to the moment we can identify and diagnose diabetes. We have here criteria for diagnosing diabetes, like a random glycemic, and we have here the criteria for the WHO or for the ADA. We know these criteria are from late 90s, and also there has been introducing A1C as a criteria in the 2010 by the American Diabetes Association, and lately by also the WHO. Here we have also some controversy about the prediabetes. Not everybody is considering prediabetes because it's considered like a pre-disease. And sometimes there are concerns about trying to put a label to a person living with a pre-condition or a high-risk condition. But here we have what is considered for this WHO or ADA as a criteria for identifying that person's on that status. what we know that those persons that are suffering or identified as impaired glucose tolerance after 10 years evolution, and this has been published in the Lancet like some years ago, 50% of those can follow up to diabetes. 25% of them remain as a impaired glucose tolerance, and 25 go back to the normality. So that it means that some of these persons living with that situation of high risk of diabetes could be reversed to prediabetes, or could be reversed also to normality. Here we have this review of papers published in 2015, where we have here all the trials at the moment that has been showing benefits in terms of diabetes prevention. In this green code, we can observe those ones that are assessing the benefits of diet and lifestyle, and also with medications, not just for diabetes, medications that sometimes are for obesity, and also medications that could be also for hypertension. But I would like to be focused on this aspect, on the diet and lifestyle. So why? Why we have to work about the importance of lifestyle in diabetes prevention? Because we have some already clinical trials that has been showing that benefits. But of course, as you see in that slide, the DPS, Diabetes Prevention Program, one has been studied that has been developed in Finland with a leadership of Jaakko Tuomiletto and Jana Lindström, observed a reduction of 58% in progression to diabetes with an NNT of 5.2 after 4 years of follow-up. So it seems that it has sense, although from the clinical trials, that we have benefits in terms of lifestyle. And these benefits, I didn't show you, are higher to those ones has been observed with oral medications used for diabetes as metformin or GLP or glitazones. So who can be a candidate to provide this kind of approach? How we are going to identify them? We know at the moment we have different systems that allow us as a clinicians to identify that high-risk individuals. We have questionnaires as the FinRisk and others available from different countries that are adjustments or maybe new questionnaires developed in that countries that allow to identify those high-risk individuals. But of course, besides having that scores, we have to know that many of them probably are identifying that persons living with this prediabetes situation, but it's very important to know if that scores are validated in our population, and also if that ones are adjusted and calibrated for our citizens. FinRisk is validated by different studies in our country. So we decided to take that questionnaire. It is a very wide use at the global level, also in Latin America and in many countries, in Italy as well. So we decided to move for that one. We also did a study of validation in Catalonia. But of course, when we have this kind of tools and it's validated, we know that sometimes that ones are not really accepted or used in the primary care, because it's sometimes a questionnaire that is really not really known by the healthcare professionals, or they consider that they are not really useful. Or by the citizens, they consider that they are really the result or the consequences of what they are observing from that questionnaires could be scaring them, and they don't want to be tested of something that is a high risk situation to have diabetes. So for that reason, I think it's important probably to make guidelines or to have guidelines or consensus that allow to know what is the best approach in terms to manage prediabetes. And probably if we can have incorporated different parameters that including on that questionnaires on our electronic clinical records that can detect automatically what are these subjects, and the system can pop up that could be a person with that high risk situation. Of course, these diabetes early detection strategies could be done also using fasting plasma glucose or A1C to determine the prevalence of the disease, and also assessing clinical and demographic parameters, okay, that could be also allowing us to estimate this likelihood to have diabetes. And of course, as I said you before, the completion or the fulfillment of that questionnaires that provide that risk. Of course, what are the ideal candidates, or what are the persons that we know, general population, but mainly are overweight or obese citizens. So we have different studies that also tries to incorporate to that different systems what is the measurement besides the questionnaire, adding some parameters as the abdominal circumference, the BMI, of if the patient was suffering of cardiovascular disease before. So I think, and this is a Cochrane Library review, that of course it's important that we identify that a person suffering of what is said intermediate hyperglycemia. It will be impaired glucose regulation that could be becoming worse over time, and we know that these persons can have a higher risk of becoming diabetic, and probably it's very important to identify them by some systems that allow us to screen and to detect that situation. In a study that we published in 2012, we detect that, I'm going to provide some data later on, we observed that those persons living with two conditions of prediabetes, like impaired fasting glucose and impaired glucose tolerance, have 10 times more risk, 10 times fold, to have diabetes on 4 years follow-up. That it was how this study was designed. But of course, it's according in what category we are identifying. If you are suffering for impaired fasting glucose, or you're impaired glucose tolerance, or both of them, the strategy you have to follow must be going to be different, because we are facing different phases of, or different phenotypes of the disease. So how we are going to this diabetes prevention? We, as said you before, I show you in that bars, what is the impact in terms of reduction from the randomized clinical trials using lifestyle, the Malvo study, the Indian DPP, the Dutch study, COSAWA, the diabetes prevention program in the US. But as I said, the DPS, that is the study that we decide here in Europe to follow. And this DPS, it's well considered, it shows clearly this 58 reduction with this NNT of 5.2, an efficacy component, but we have to move to what is going on in the real life, and to identify and assess what is the effectiveness of that intervention, and if it also is feasible to do it. So for that reason, it was decided and it was designed in mid 2004, the project D-Plan study, and later on also in Catalonia, the D-Plan study. But that has been funded by the European Public Health Agency, the DG SANCO, that approved that project in 2004, that is the D-Plan study. This D-Plan study was run, as you see here, in many countries, in many settings, and that allow us to test first, identifying subjects with a high risk of diabetes using a questionnaire as I present to you before, the Finn risk score. And when the scoring was over or equal 14, that patient was invited to be also done an OGT test. And according to the results, the patients were included on the project, as has been described here on the D-Plan intervention. This is the design of the D-Plan. Is as I said, is a public health study funded by the Public Health European Agency. It was considered a 2-year study. But of course, we in Catalonia, we decided to do this study as a base of a longer study, 4 years from the beginning, not just 2, just to assess and trying to estimate what is the impact if what we observe in the DPS, in the diabetes prevention study in Finland, could be also how that be translated into primary care in Catalonia. So we have here, I'm going to speak about these 2 papers. We have other papers published on that project. But just to inform you what is the D-Plan study, that is the core study, is a cross-sectional observational study with a population sampling or opportunistic sampling in primary healthcare centers in Europe, and with these persons from 45 to 75 years. And that has been done, the studies that has been presenting in this one of these papers is in 9 centers. What has been done is to fulfill the Finn risk and also invite the participants to do an OGT test, oral glucose tolerance test. The fin risk is described here. It's exploring 8 dimensions, and this can be self-fulfilled by the participant. This is published in many countries by the news or by the newspapers, or you can download from the internet. And of course, this is the results from these 9 centers, and this is the first paper published from the D plan. We have, including in total, more than 4,000 persons. And as we can observe here, according to the different categories of fin risk, we can observe that those ones that have higher categories in 15 to 20 or over 20, we have worse values of systolic blood pressure, triglycerides, BMI, and waist circumference in both genders. And when we observe also daily physical activity or vegetables intake, we observe the contrary in terms that the lower categories have higher percentage. Here we observe in terms of what is the prevalence of carbohydrate metabolism abnormalities, and we can see observing that in the blue bar, the men's, and in the red, in the women, we can observe that is a trend of increasing from 15 to above of the risk of having these alterations. And also when we go to the diabetes, we observe that those ones having over 20, around 50% women and men, we have already diabetes at that moment. Of course, but how we translate this into the D-plan study to the D-plan cut? And this is a paper published in Diabetologia in 2012. This has been done in Catalonia in 18 primary healthcare centers, that it represents 4.5 citizens of Catalonia. That is a 4 years duration study. Researchers are primary care and primary care nurses. The inclusion criteria are those ones described here: no diabetes, this age, running primary care. And this is that the exclusion criteria: have a liver disease, kidney disease, have some hematological disease, or having also a stroke or cardiovascular disease. So this is also double screening, as I said you before, fin risk and OGTT test. Also, we invite the participants to fulfill questionnaires, the basic questionnaire and the quality of life questionnaire. We have here the categories. In that study, it uses a public health study. When the patients have over 14, if lower 14, the OGTT test was optional. We identify from the OGTT test 3 categories. And when we have over 14 in the fin risk scoring, we have OGTT test was recommended. Also, we observe these different situations after the OGTT test, and we finally include those ones on the main study in the D-plan study. So we follow the patients every 6 months, and also we perform an annual OGTT test, and also the intervention was standard or intensive. The standard intervention was some established goals, and with current primary care lifestyle advice, nothing special. We provide a leaflet and no reminders. But in the intervention intensive, it was the same goals as the Finnish study that it's described here, trying to reduce the saturated fat, increase the fiber in the diet, trying to promote physical activity, and try to promote also weight reduction above 3%. It has been done due different topics, lectures or workshops, and in group or individual, diabetic education, motivational interviews, and also it was the patient can decide, or the participant in that case, to go to a group or individual intervention, and also we send reminders by SMS or telephone calls. That has been the different blocks of the topics of the lectures we provide in individual or group manner for 1 hour and a half each. Intro, diet, exercise, tobacco, if the patient was a smoker. This is the design we have here. It was a 4 years study, and we, as I said, provide every year OGTT test. We have here the parameters. Remember, these patients this is not a randomized clinical trial. This is a study where the citizen can decide to go to one intervention to the other by preference, but we invite them as a consecutive sampling. And we have, as you see here, the distribution. It was no difference according to what we observed in the baseline analysis. The important thing here is what we observed after 4 years intervention of just 4 teaching activities of 1 hour and a half each at the beginning and the inclusion moment. After 4 years follow-up, we observe that reduction of risk of 36.5 is not the 58 observed on the Finnish diabetes study in that clinical trial, but this is a real life study observing that it means in terms also of being free of diabetes, that we have an NNT of 9.5, providing this lifestyle advice. When we also try to observe, and this has been shown before, what are the categories that have a higher risk of to follow to diabetes, you see that when you have living with the both conditions of impairing glucose, is that having impairing fasting glucose or impairing glucose tolerance, you have a risk 10 times more risk to evolve to a diabetic, moving from pre-diabetic situation. Here we have the two different study outputs, and you can see observing, comparing 58 reduction, 36 reduction, and the NNTs. Of course, that it was thanks, and that provides also another project funded by the European DG Sanco, the public health is the IMAGE project. It is available, and it provides how to provide education and what is the kind of education that works in the primary care. Of course, also there are some publications coming from the Cochrane Library trying to show what are the benefits of dietary physical activity. An important remark here is to take into account that is not any of those done just alone has been effective. We have to provide both at the same time, that it has the ones that have providing diet plus physical activity delays the incidence. In terms of long term, that is also a challenge. We have to be very clear that is uncertainty sometimes about what is the impact long term of interventions, in terms also in sustainability of the effect in the real environment, and also how adherent are our participants to these lifestyle changes. And I think it's important to know that although we have these interventions, although you are moving back to your former diet or your former behavior, if you have already some changes at the beginning, that can go for a kind of metabolic heritage or metabolic memory that allow you to have a better prognosis in the future. But of course, we know that for incorporating some technologies as pedometers or others that has been done in the DPP study in the US that have benefits in terms to provide or increase adherence in our patients. In terms of cost effectiveness, I think this is a very important thing to do when we are trying to incorporate a new aspect in the primary care. Is that cost effective? It has sense, besides that the efficacy and the effectiveness. And we also did this cost effectiveness analysis has been published, as is the Preventive study. And also there's it's a systematic review trying to see what is the cost effectiveness of these interventions in the primary care setting. But I think, and this is, I'm just reaching the end of my talk, it's very important to see when you have something that you know that it works in the primary care, it's a big challenge, how we can translate it into the real environment, into the real world. And this paper has been published in the 2014 and try to summarize that when we have an intervention that can try to be implementing a primary prevention of health promotion, there are some barriers we have to know in the different rings that we have to take into account, besides having the big effort that it means to have a good design that trying to translate a clinical trial into real life. Besides that, and we have now results in efficacy, effectiveness, and cost effectiveness, we also have to design a good plan of translation into real life. And that is now also being studied in this project nowadays in Catalonia and published in another project called DP Transfers. Of course, we have to move forward. We have to try to move far from just screening and treating. We have to try to individualize the screening and using, as I said you before, validated tools. And I think it's important to identify those high-risk people, those high individuals, and because they are also a cost-effective interventions. Adherence is crucial. And I think we have to move for trying to have that activities that allow us to promote the adherence using some technology that support us, as has been done in the DPP study, the American one in diabetes prevention. Also other initiatives are trying to create social network as the Pride project, and also how the pharmacists can be also helpful in that. There's not many countries where the pharmacists also consider as a provider. For example, Spain, pharmacists are not considered provider, but I know in the UK and other countries as well. And I think pharmacies or pharmacy offices can play an important role also in diabetes prevention, and also the community pharmacy as well. So I've been trying to provide answers on the why, who and how to manage the diabetes prevention. And that are my final and take-home messages. I think the FIN-RISK is a questionnaire that is practical screening tool that is applicable in the European population, as has been shown on one of my papers I showed today, and particularly in the primary healthcare. As I show you also in this study, the D-Plan CAD, we know that the FIN-RISK and the plan, the FIN-RISK can be, when it's scoring above 20, we have around 80% of persons living already with some glucose alteration. And also we know that 50% of men and women had type 2 at the moment. It's important to have a structured diabetes prevention program based on an intensive intervention and lifestyle of high risk people is feasible, is effective, and is also cost effective in the primary care. And now it's time to implement, because we have a solution that is cost effective. And also I think it's really important, and this is my last message, to implement long-term lifestyle programs. Benefit require further research. And I think that is, and also the commitment of the local authorities, the public health departments in terms, and also the primary care community. So thank you very much for your attention.
Thank you, Kos, for the short and very condensed lecture. And now I'm opening the stage for questions. I saw that there are many, many questions. So please try to give short answers in order that we will answer as much as possible questions. So Bert, the stage is yours.
Yeah, thank you very much, Shlomo, also Monika and Xavier. So the first question is about the trustworthiness of guidelines. So the ESC is highly supported by the pharmaceutical industry, more than 75% of the income, and many of the guideline authors are or have possible conflicts of interest. So what do you think about those guidelines then? Perhaps it's a question for you, Monika.
Well, yes, I am familiar with the fact that these organizations depend heavily on pharmaceutical industries for sponsoring. However, I know that if you are part of such a guideline committee, you have to disclose all your all your bonds with such parties. And there are also measures being taken to prevent the influence of such pharmaceutical industries in the writing of the guidelines. But I think this is a difficult question, and it's also related to other GP societies. Can we do this without any sponsoring? I think this is a general question. How can we make progress without it? And you would like to diminish this as much as possible. But to conclude then that those guidelines are not based on real evidence, and that we should disregard the guidelines because of that, I think this is a bridge too far. Okay, I think this is the correct answer about this, and it's a very important topic or issue, because what is the step or the bridge between evidence and a recommendation? Okay, next question. If your patient is originally born and raised in a high-risk country, but he moved to another country, do you use the score chart of the country where he was born in or raised, or the home country? So did change his risks? Well, I think you always should think it is, and I think it also depends on how long the person is already living in the new country, because we know that food habits are taking over from new countries. So I would say if it's a few years when you are young, and then later you have decades in the new country, you should take over the risk of the new country, of course. If it's only 1 year and you have moved as an adult, I would say take the low risk for this. So there's no clear answer for this, and I think you should use your common sense to interpret this question.
I want to add a remark. I really agree with you, because, for example, the patient that you gave had a very long history of smoking and only 1 year smoking cessation. Again, the question, which score to you, smoker or non-smoker? So what I would say that all those scoring systems are only a guide, and at the end, you have to feel and work as a clinician and not as a robot.
Yeah.
And this is also that you have to discuss this with the patient. So your risk is this, but given the fact that you have been smoking, it might be slightly higher. And this is the way to go. I fully agree with you.
And so since we have a lot of common sense as GPs, it wouldn't be that difficult. Okay, thanks. Xavier, a question for you. So a lot of people asking lifestyle changes are of utmost importance for cardiovascular prevention. However, this is a weak area in today's medicine. What do you think, and perhaps you have given us an answer already, what do you think of projects not just prescribing lifestyle changes, but providing exercise facilities and healthy lifestyle groups attached to GP practices?
I think this is
like you've shown us.
Yes, I think that has been partially answered. It was the PRIDE project that I also provide some remarks. I think, for example, the DPP in the US also did a strategy of implementation. They tried to do it in the YMCA centers across the US. It was the CDC who promoted the idea of working mainly on the overweight and obese patients, calling them to go to the YMCA centers to have these group sessions in terms of lifestyle. Because what happens sometimes in these clinical trials, like the DPP or the DPS, that they are very idealistic. There are a lot of coachings, and this is not really feasible to be implemented in the real life. When this has been considered by the DG Sanco, the public health agency in Brussels, in terms to approve a project, it was considered we have to do something feasible, okay? And the idea of translating what is suggested by the Finnish study to the European study, where many countries from Europe try to implement that strategy in the public health domain, and having 4 hours teaching in group sessions, I think that it has a benefit in terms of having also these group people together working. And now we have also already some public publications using technology online. Our group also is developing this in an online system also, and trying to catch other a set of ages, just to also not just the elderly, because the elderly could be in life, but other people are not keen to come to the centers for that sessions and prefer to do it remotely or in an online system. And also this is working at the moment. So I think lifestyle is working. Also, there are projects. I mean, these big studies on lifestyle, that there's the Chinese one, the Daqing study, also published 25 years after starting this project, benefits in the cardiovascular domain. So I think, of course, lifestyle can have benefits on the cardiovascular field as well, and also as preventing diabetes, as I showed you before.
And how do you think that we as GPs or GPs practices can be involved in a community to reach that goals?
I think that we have to know how is the primary care organized in each country, because it's, as we know, probably if we know how we are providing care in a very different manner country to country. I know that in Belgium, sometimes it's very solo practice. Okay. We know, for example, it depends, but I have colleagues in Belgium, in Belgium that are working solo practice. Is different than in France, or is different that for example, in Spain, we are working in group practices, mainly in the cities. My center, we are working 30 GPs together with nurses. But of course, I think that when you know this landscape, I think it's very important to know what are the social determinants that also you can probably have a facility by the municipality, or you have some facility. Some municipalities are also involved trying, for example, in Barcelona city, we ask from the primary care center to put some specific machines to do some training for elderly just next to the center, and the municipality accept that and put that the elderly people is going there to do some gym. And they are starting, and also we promote from the primary care center to go runnings, to go walking tours around the center and in the neighborhood. So there are some activities, and I know in the Netherlands, they publish papers about the benefits of doing the activities from the primary care. So we have to be innovative, disruptive, and try to see in our setting what we can promote in terms of lifestyle.
Okay, great. Thanks for the answer. And perhaps just one more question. In cardiovascular risk management and diabetes prevention, we distinguish groups according to the risk. But how can we deliver person-centered care in general practice? Perhaps this is a question for both of you.
Monika first.
So moving
shall I start? Yeah. I think this is a very important question, and well, we should not. You need the categories to categorize the risk of the patients, but then I think our skills come in. So the patient is not just a number or just a square in a risk score or a point, but it is very important to discuss with the patient what the meaning is of this. And I think there personalized care is coming in, and we should discuss what are preferences of patients, if elderly people, how frail they are, and what they want, what are side effects, what are comorbidities. And I think this is the heart of what we do as GPs. So I don't see this as a problem, right? But I think it's an opportunity in just where our strength is. So
I think we have to move to a very clear way of how we are involving the person in that process. And the person is the driver to be moving to a better attitude, to a better behavior. And I think here I consider myself as a facilitator, as a kind of mentor. And I have to support the person to make decisions, because the decisions are made by themselves, not because they have to be relying on me. We have to move far from the paternalistic model. And what are the capacity the patients have at that moment in the present to do that movement? And then we are breathing and we are testing the temperature, and we are trying to coach if we can move for a more aggressive advice, or we have to go for a more moderate advice. But I think it's important to create this confidence, this good adherence first, and then see what are the goals we decide, and we can move forward and we can pursue that specific goals, and of course assessing and being committed with the goals.
I can have a comment also. As you are moving from medications, operations, and so on to lifestyle, it must be patient-centered, otherwise it will not work. And we are just getting out of time, so I think we have time for one or two more short questions, Bert.
Yeah, just one more question, I guess, about, and it's not about lifestyle, but what are your thoughts about treating with example, metformin for pre-diabetic people, taking into account that they are healthy subjects, just to prevent diabetes?
Yeah. This has been shown by the DPP, the first one, the Diabetes Prevention Program, and the reduction observed, it was 32%. Observed 32% reduction in a clinical trial, when in a real world study, in a primary care study, we observed 36% with lifestyle. So the lifestyle in a realistic, primary care, in a real resources, is detecting better impact than in a clinical trial, a drug. The only thing here.
And Xavier, sorry, but are these the same people? So it could be that you have a proportion of people, the 36%, who are able to do the lifestyle changes, but perhaps another 30% are more appropriate for the metformin. So, and then you have 60%. I don't know.
This must be phenotype. What is the best responder? And I think that according to the characteristics and probably the artificial intelligence and the machine learning with the big databases allow us to identify which one are the subjects that are better responders to diabetes prevention in metformin or in lifestyle. But I think that we have to learn what we can distill from the real world evidence with these big databases, and how this can provide us additional information of what we know at the moment. But in many countries, metformin is not support to be used in a pre-disease. Okay. In other countries, they are used off label. Okay. So we have to be clear that, of course, it's not damaging, because we know metformin is very beneficial for other aspects, but it's a medication, and we have to be adhering to take a medication long term. But the most important thing is weight reduction, okay, over 3% or 5% more, and also lifestyle, both combined. This is the more effective intervention. And now in some countries, they are start talking in some projects in diabetes remission. It's like eliminating diabetes thanks to these kind of interventions.
So I see that Bert unmuted his microphone, so I will take the stage and say thank you to you, Monika, thank you, Kos, thank you, Bert, thank for all the audience and very interesting questions. I saw that there are many more questions. Usually we are not able to answer all of them, and I'm sure that Bert chose the most important ones or the ones that gained most popularity by voting. As you know, you can vote for the questions and raise them up to the beginning of the list. So thank you all and continue to enjoy the conference. Bye-bye.